Kia ora koutou. Hello and welcome. I'm Adele Gauthier from Breast Cancer Foundation NZ, and tonight we're talking about 30,000 Voices, a new report that reveals how well we're doing in treating breast cancer here in Aotearoa, New Zealand, and how we might do better. So tonight I'm going to start by giving you some background to our new report and an introduction to some of the data, and then we have three experts who will give their take. We have Dr. Rina Ramsaru, who's chair of Breast Cancer Foundation's Medical Advisory Committee and head of clinical pathology at Waitemata DHB. She'll look at the different kinds of breast cancers diagnosed and what factors contribute to survival. In the second box on your screen, you'll see Professor Ian Campbell, a surgeon from Waikato DHB. He'll comment on the findings relating to surgery and radiation oncology. And then we have here back on my screen, Associate Professor and Retired Medical Oncologist, Dr. Ben Harvey. He will talk about drug treatments and go through the survival data. And then briefly at the end, we'll come back to Rina to talk about where we might go from here. And then we'll open up to your questions. Right, so let's move along. Let's click on the screen. Great. Oh, let's get that. Okay, so the 30,000 Voices report. This report uses data from Te Rēhita Mate Ūtaetae, the Breast Cancer Foundation National Register. And what we're talking about tonight is data from 4 regions: Auckland, Waikato, Wellington and Christchurch, actually 9 DHBs. And these represent about 70% of, 65 to 70% of breast cancer diagnoses in New Zealand. The reason we're not covering other regions in this report is because until recently, only those regions have been in the register. Next time we do this, we'll be telling you about other regions as well. But what we looked at in this report is who gets breast cancer in New Zealand and how are they diagnosed? Is it through a mammogram or do they find a lump? When they are diagnosed, what kind of treatment do they get? What kind of cancer do they have? How big are their tumours? And ultimately, what is really important, most important for most of us, is how good is our survival? And just one thing I want to say about survival, as we talk about it in this report, we're mostly focusing on 10-year survival. Often in cancer, you hear people talking about 5-year survival. That's because in some cancers, 5 years means that there's very little chance of the cancer coming back after that. Unfortunately, breast cancer isn't quite like that. You actually have about 40% of recurrences of cancer coming back happens after the 5-year mark. Okay, so this report looks at data from 30,000 women and 181 men who were diagnosed from 2003 to 2019. The register data that we've used in this report, we've combined it with some national data looking at, including from the Ministry of Health and Statistics New Zealand, with some expert commentary by local and international experts. And then we've analysed that by a team at the University of Auckland, and we've run it past a whole lot of clinical specialists and Māori and Pacific commentators to get their view on it. Why did we want to do this? Well, we wanted to understand the gaps and inequities that exist in breast cancer in New Zealand. And we wanted to help people who are decision makers in this sector make really good decisions using real world New Zealand data. We've identified some key areas for action that we think as Breast Cancer Foundation could improve outcomes. And even where things are already going really well, where are we at risk of perhaps losing ground if we're not careful? So we're talking about those areas too. We're informing advocacy by organisations like us and other charities, and hopefully forming a baseline for future studies. The really important thing here is to say that we're not measuring for measurement's sake. We really see this, the idea of putting all this data out there is that it's an opportunity for change. So I'm just going to quickly run through some of the basic demographics. Who gets breast cancer in New Zealand? Overwhelmingly women. About half of 1% are men. That's in New Zealand, that's around 25 men each year diagnosed with breast cancer. But pretty much what you're seeing in this report is data about women. Around 3/4 of patients are European, and then with other ethnicities, you'll see it kind of aligns with what we expect around the population in New Zealand. So higher percentage of Māori in Waikato, Wellington, then Auckland, and then the highest percentage of Pacific diagnoses in Auckland, followed by Wellington. And how old are they? Well, you've probably heard that cancer is an older person's disease, and that is true. You can see our graph kind of skews at the older end, but the median age in this report is actually only 58, which is not old, I like to say. Europeans have a slightly older age at diagnosis, median age, and Māori, Pacific and Asian are all younger, and that can be because they have a younger population. Overall, a higher percentage of young people, but also can be because of shorter life expectancy, meaning a smaller percentage of older people. And in some of those ethnicities, cancer just does occur younger. At the bottom of that screen, you can see a bit of a breakdown across sort of some umbrella age groups, if you like. And you can see about 13% of people under 45, 45 to 69, that's the free screening age. And we've divided that into sort of a premenopausal and a postmenopausal group. And then we have the over 70s, who are about 1/5 of diagnoses. And then we're going to talk next about how breast cancer is diagnosed. And we talk about two things here. We talk about screening, where we mean you have a mammogram, you have no signs of breast cancer, but you get a mammogram as part of a health checkup. And symptomatic, which is when you find a lump or another symptom and you go to your doctor about it and get diagnosed that way. You can see that about 45% of people are diagnosed on screening, and that's reasonably consistent across ethnicities. When it comes to ages, as you'd expect, by far the highest percentage of screen diagnoses is in women in the free screening age group. Very few under 45 and still not too many over 70, because that's when people have to pay for mammograms. The way they've been diagnosed has changed over time. This is good news. You can see right at the start of the study, 37% were mammogram diagnoses, and now it's getting up towards 50%. Why does that matter? Well, it makes a real difference actually to survival. So that's why we pay a lot of attention to how breast cancer is diagnosed. And if you look here, you can see that the difference in 10-year survival, 95% for screen diagnoses, 85% for symptomatic. Now, I just want to say something about survival on this chart and all the other charts that you'll see in this presentation. All these charts are what we call raw data, and they're just the data exactly as it happened, if you like, and it's not combined with other factors. So although these factors are true about screening and symptomatic, in reality, there'll be other factors that affect survival, such as the type of breast cancer, the stage it's diagnosed at, how aggressive it is. All kinds of things actually feed into an individual person's survival. So don't take this as kind of your individual survival prediction, because it's absolutely not. But this does help us identify what makes a difference here. And looking at screened and symptomatic survival by ethnicity, you can see what a huge difference screening has made for Māori and Pacific people in particular. That gap is really narrowed between the ethnicities once you get people screening. And in fact, Professor Ian Campbell, who you'll hear from later, he's done a couple of very good studies that show that when Māori and Pacific breast cancers are found on a mammogram, their survival is exactly the same as European, pretty much. So really highlights the importance of that. That's it from me. I'm going to hand over to Dr. Rena Ransroot now. As I mentioned, she's the chair of our Medical Advisory Committee, and she's head of clinical pathology at Waitemata. Rena, what does the report tell us? Let me just zoom in on you so that people can see you. What does the report tell us about the kinds of breast cancer women get? What does it all mean? Can you click on the slide, please? Yeah, thank you.
Thank you, Adele, and good evening to everybody. I'm a surgical pathologist at Waitemata, as Adele has said, and in my role as a surgical pathologist, I have to examine tumours, every tumour, and decide and provide information on the tumour characteristics. This pathology information is for clinicians like Mr. Ian Campbell and Dr. Vernon Harvey, the oncologists and surgeons, to decide on treatment options. But before we can even start about looking at the detail of tumour characteristics, we have to establish what type of tumours New Zealanders get. On the first pie chart, you can see that about 15% of tumors diagnosed are what we call in situ cancers. That's the light blue bit of the pie chart. And in situ cancers means that the tumor is still confined to the ducts and not spread into the surrounding breast tissue. From the second chart, you can see that about 80% of in situ cancers are diagnosed by screen mammogram. And this has gone up over the years as the screening mammograms have increased and there has been increased uptake. We as pathologists divide duct carcinoma in situ into 3 grades, a low, intermediate, and a high grade. And this reflects the behavior. So the low grade duct carcinomas in situ usually behave in a low grade fashion, whereas the high grade lesions are the ones that have a greater potential to invade into the surrounding breast tissue. If we come back to the first chart, we see that the vast majority of tumors that fall into the second category, which is invasive carcinomas, 85% of them. And in the rest of my presentation, all the information that I'm going to give you will relate to invasive carcinomas. So when we look at tumors, we have to look at certain factors and indicators under the microscope and examining the gross appearance of the tumors so that we can look at indicators that will predict or will help to decide what treatment options are available and also will relate to long-term outcomes. The first thing that we look at is tumor size. And all of you must be aware that the earlier we diagnose tumor, the smaller they are, the better the outcome. And from these bar graphs, you can see that pink is good. So the tumors that are in pink, almost 62% on the top line, are less than 20 millimeters or less than 2 centimeters. So they are regarded as T1 tumors. So they're small tumors and they do well overall. The chart on the far left-hand corner, the olive greens, are the larger tumors that is greater than 5 centimeters. And if you just look down to the second set of graphs, you will see that it's young patients, less than 44 years, and Pacific women are the ones that will get larger tumors. Why? But the good news is that over time and with the increased uptake of screening, you can see that the smaller tumors, the pink bars, have gone larger, and the olive green bars or the bars on the left-hand side have gone smaller. So the good news is that with increased screening uptakes, there has been increased detection of small tumors, less than 20 millimeters, and a decrease in the numbers of large tumors. So the second thing that we look at under the microscope is tumor grade. Now, invasive carcinomas are graded just like in situ, but using different criteria. And we use a grading system of 1 to 3, with grade 1 being a low grade or a good tumor that resembles normal breast tissue, whereas grade 3 tumors are the bad end of the spectrum, the more aggressive type of tumors. There is a sort of a 1/3 distribution between grade 1, 2, and 3 tumors. If you look down at the age group, you will see that grade 3 tumors are more likely to occur in young patients, less than 44, and within the ethnic groups, you can see Pacific, Asian women are more likely to have grade 3 tumors. Why does this matter? Because grade 3 is an independent indicator of survival. And you can see there, pink line are the grade 1 tumors, and they do excellently, 99 and 98% 5 and 10-year survival rates. In comparison, our grade 3 tumors, which is the olive green line, have a poor survival rate at 87 and 82%. So tumor grade is an important indicator of overall outcome. Breast tissue normally needs hormones and growth factors to grow, as you are aware, and so does tumors. So as pathologists, we will look at tumors to identify whether they display receptors for hormones and for growth factors, the common one being HER2. The pink again is good, and you can see that almost 75% of all tumors diagnosed are hormone positive. And this is important because these patients are amenable to anti-hormone therapy, and which will alter their long-term survival. The middle two columns, the light blue and the olive green, are patients that have HER2 positive tumors, and you can see that these tumors are more prevalent in young patients. Again, looking less than 44 years, they have a higher rate of HER2 positive tumors, and so do the Pacific women. The last column, the dark blue, are the tumors that do not display any receptors, hormone receptors, or HER2 receptors, and we label these tumors as triple negative. They are usually the more aggressive type of tumors, and they can only be treated with chemotherapy. Again, looking at the weight of the triple negative tumors, you will see a higher incidence in young women, predominantly. So almost 15 to 14.5% of tumors in young women would be triple negative tumors. Again, this is important when we look at overall survival. And remember what Adele said right at the beginning, these are just as it appears in the register and not affected by other factors like treatment or size of tumor. So the hormone-sensitive tumors are in the red or pink line, and you can see that their overall survival rates is very good at 92% at 10 years. It's also worth mentioning right here that the HER2 or the hormone-positive tumors are the ones to watch for at a long term, because they are the ones that usually recur at greater than 5 years, 10 years, or sometimes 15 years after diagnosis. In contrast, the triple negative tumors do quite poorly, looking at a 10-year survival rate of 79%. So it is important to advocate for chemotherapy for these patients, especially remembering that most of these tumors will be in younger women. Lastly, we look at how far the tumor has spread, and we get this by calculating the stage of the tumor. The tumors can be divided into 4 stages, with the early stages being stage 1 and 2, and that's represented by the pink and the blue bars on the top line. And so you can see about 75% of the tumors will fall into this category. And the stage 1 tumors, stage 1 and 2 or early tumors, are usually detected by screening. So it's not surprising if you look at the last group of bars that most of the tumors are found in the screen age. Most of the early tumors are found in the screen age group. In contrast, if you look at the last left-hand corner, these are the tumors that are stage 4 lesions. They are smaller in number, but they usually occur in Pacific women and to a slightly more extent in older women. The stage has, due to the increase in screening uptake, we've seen this reflected in this chart where the stage 4 tumors have decreased over time. The stage 1 and 2 tumors have increased in numbers over time, which is a good outcome. And this has happened for all groups, all ethnic groups, but more for Maori and Pacific. And you can see both of that reflected in these graphs. So a decrease in the late stage disease. And this is important, once again, because stage then reflects survival, with early stage disease, stage 1 disease, showing a survival rate of 99% and 97% over 5 and 10 years. And we do really dismally when it comes to stage 4 disease, because we fall down to 16% at 10-year survival. So the message to take home is early detection, pick up tumors while they are small size and early stage, and outcomes are really good. I will now hand over to Professor Ian Campbell, who's a breast surgeon at Waikato Hospital, to talk about surgical treatment of breast cancers.
Thank you so much, Rena. That was great. Now, just a reminder to people at home that if you have any questions, please do put them in the chat box for us to get to later. And as Rena said, we'll now hand over to Ian to tell us what the study says about surgery and radiation therapy. Thank you, Ian.
Thanks, Adele. It's a great pleasure to be able to talk to everyone about this amazing piece of work that the Breast Cancer Foundation's put together. Get my screen control sorted. Okay, so first of all, we're going to look at the surgical treatment of breast cancer, and this bar graph shows the proportion of women who've had breast-conserving surgery as opposed to having to have a mastectomy or removal of the whole breast. And in pink on the bottom there, can you see my pointer?
Yes.
Or not?
Yes.
Okay, so on pink, this goes by time as well, and you can see that over time the rates of breast conservation have gradually gone up a bit from just under 50% to, in the latest time period, up to 55%. So perhaps not as good as we might hope with breast conservation, but something that's getting a bit better with time. And this graph looks at the variation by ethnicity, and you can see that for European women, the breast conservation rate overall is just over 50%. It's much lower for Pacifica women at just under 40%, and that, and probably to quite a major degree, reflects the size of the breast cancers that are being diagnosed in these different populations. So as you saw from the work that Rena presented, Pacifica women on average are being diagnosed with breast cancers that are larger in size, and with larger breast cancers we often have to do a mastectomy rather than preserving the breast. You'll also see, perhaps slightly surprisingly, that there's quite a high mastectomy rate, a low breast conservation rate amongst Asian women, and that reflects in part some cultural views, perhaps that they prefer mastectomy in some cases, but it also reflects the fact that especially women from a Chinese or Japanese background, for example, often have somewhat smaller breasts, and it's harder to preserve a smaller breast with a moderate-sized breast cancer in it. This looks at the range of rates of breast conservation by region, and you can see there's quite a bit of variation. So in all regions, the rates of breast conservation in pink have tended to come up with time in each of the time periods. You can see they've come up a bit more in Wellington with time and in the Waikato. And I think that reflects a couple of things. Overseas studies have shown that what the surgeon recommends is very influential for women. So it reflects an increasing commitment by surgeons to try and go ahead with breast conservation. And I think it also reflects the development of new oncoplastic techniques, use of breast reduction type techniques to help us preserve breasts for women with larger breast cancers and still get a decent aesthetic outcome. It's no good taking a large tumor out of a breast and leaving women with a very deformed result. So we need to also be able to get a reasonable aesthetic outcome to make life reasonable down the track for these women. This looks at the type of surgery by age, and as you might expect in the screening age range, 45 to 69, we see a much higher breast conservation rates because if we find tumors when they're smaller, not only the chances of long-term survival much better, but it's much easier for us to do breast conserving surgery. So another big plus for breast cancer screening, that we can more often preserve a breast. For women, younger women, we saw that more young women present with later stage breast cancers, and they often more commonly have multifocal breast cancers and more commonly have significant family history or even genetic factors which may influence the decision to have a whole breast removed rather than a breast conserving operation. And in older women, besides more advanced stage at diagnosis on average, the number of older women simply prefer one operation. They don't like the possibility that they might need more than one operation if they have breast conserving surgery. And for some, it's nice. They prefer not to have to go through radiotherapy. And that's another factor that may influence having mastectomy ahead of breast conserving surgery. This picture looks at the proportion of times where we have to come back after a breast conserving operation and do a second operation. And so in blue, you see the proportion of cases where a second operation is required. And it's about 20% across all regions, which is very good by international standards. It's the generally accepted sort of standard. So in the UK, a bit over 10 years ago, a report was published on this kind of data by region, and there was massive variation over there from about 10% of women requiring a second operation in some areas through to over 40% rates of reoperation in others. So it's nice to see that in New Zealand we seem to be very much more on the middle ground and what's generally accepted by international standards to be an appropriate rate. Most women faced with having to have second operations are pretty disappointed, I would say, and they find it a major hurdle. Although for us as surgeons, it's not such a big deal to go back in and take a little bit more tissue in some cases. For patients, it's a big hurdle and a big deal, and it costs money, resources, recovery time, etc. On the other hand, if the end result is to be able to conserve a breast, that's a very important long-term goal as well. This picture looks at time to surgery, and it's time to surgery from time of diagnosis. And in pink, you see the faster cancer treatment indicator goal, well, a variation on it, because the faster cancer treatment indicator from the Ministry of Health is that we should operate on women or start their first treatment within 31 days of decision to treat. So this graph's a bit harsh on us in a sense because it goes from time of diagnosis, and that's when a biopsy report's issued, it's anything from a day to a week before that biopsy report may be communicated to women, and then it may take some time after that before a decision on what actual treatment should be done is taken. So it doesn't quite reflect the same thing that the government faster cancer treatment indicator does, but it does show some pretty important trends and information. And you can see that in time, if anything, we've got worse. And these two pictures are for Maori and Pacifica women, and in the latest time period, only about a third of Maori and Pacifica women are getting their first operation within 31 days of diagnosis, and a significant proportion are waiting 2 months or more from diagnosis before having their surgery. And the figures are a bit better for Asian and European women, reflecting in part the high proportion of Asian and European women who have access to private care, where timeliness is significantly better than in the public system, but they're still not great. They're 4 or 5% or 6% better than the figures we see for Maori and Pacifica women. So most women in New Zealand are not getting an operation within 31 days of diagnosis. And there's a lot of potential reasons for that. It does take time to communicate a diagnosis, to decide on the most appropriate treatment. And with time, we've also got more investigations that we often want to do. So for younger women or women with a bad family history, then we may want to do MRI scans and that sort of thing. And I see I'm running out of time in my chat line, so I've got 2 more slides to go. The rate of radiation therapy after breast conserving surgery, pretty good across the country by international standards, at about 90% rates of use of radiation therapy after radiotherapy after breast conserving surgery. I think the things that stand out here, Christchurch particularly good, and in women over 70, a somewhat lower rate, but we know that radiation therapy is not always necessary in women over 70, where recurrence rates are lower and other health problems compete with the need to undergo this. So the final slide, and a really important one, the crude survival by surgery type. We often have, when women are newly diagnosed with breast cancer, have them arrive and say, "Doctor, take my breast off," or "take both breasts off," because they perceive that that's the treatment that's going to result in the best survival outcome. And as you can see from this graph, which is just crude survival, the women who are doing best on this graph in pink are the women having breast conserving surgery and radiotherapy. Now, there are major biases in this particular graph, because on average, women who are having mastectomy and radiotherapy have larger and breast cancers and more commonly node positive, etc. So they have worse outlook breast cancers. So that spread's perhaps not surprising. But when you look down at the table here, these are hazard ratios, and a hazard ratio for death from breast cancer based on an arbitrary value of 1 for breast conserving surgery and radiotherapy. So if the figure's over 1, then that group is doing worse. They have a higher hazard ratio for death from breast cancer. And here, the crude data is what's graphed, but initially the statisticians have adjusted for demographic factors like age at diagnosis and ethnicity and deprivation status. And then they've made further adjustments for tumor factors like tumor size and node status and grade and Her2 status and triple negatives and all of that. And then finally, they've also adjusted for what treatment have those women had. And you can see that in spite of those adjustments, women having mastectomy still have about a 1.5 times increased hazard ratio for dying from breast cancer compared to having breast conserving surgery and radiotherapy. And that it may be that there are still biases that are not accounted for here, because the very old original randomized trials, which are unbiased, comparing these two treatments showed no difference in survival, or it may be that this is a real result, and there are possible explanations for that, because it's a consistent result in most observational studies around the world looking at breast-conserving surgery and radiotherapy compared with mastectomy, that observational studies have shown better outcomes with breast-conserving surgery and radiotherapy. So that's also the reason why we spent so much time on it in this presentation, to emphasize the benefits of going down that track, if we can, and it's not, for many women, it's not possible. Thank you. I think that's the end of my bit.
Great, thank you so much. Thank you so much. Does that sound okay? That was very interesting. Thank you very much. Now we're going to hear from Professor Ben Harvey, who was in fact one of the founders of the Breast Cancer Register. Ben, and I'll just zoom in on you. And unfortunately, our pointer here is not as good as Ian's pointer down in Waikato, so we can't point at special bits of our slides, but we'll do our best here. Ben, can you just fill us in a bit on the highlights about the drug treatments for breast cancer and what it all means for survival in the end? Great.
Thank you, Adele. Good evening. I want to share with you some slides, a few slides on systemic therapy and then a few on survival. Why do we need systemic therapy, which is therapy which circulates around the whole body when the tumor appears to be localized in the breast? That's because in a percentage of patients with apparently localized breast cancer, minute amounts of tumor have spread to the rest of the body, and if not treated in time, will lead to recurrence of the breast cancer. And once breast cancer's recurred, then it's no longer curable, so we want to obviously catch it before then. There are a number of early treatments, what are called adjuvant treatments. The commonest one and the one known longest is endocrine therapy, which is the same as hormone therapy, or more strictly speaking, it is actually anti-hormone therapy. We know that estrogen, the female hormone, promotes growth in breast cells, but in the majority of breast cancers, it also promotes the breast cancer. You can treat that by giving patients anti-estrogen therapy, tamoxifen and aromatase inhibitors. And this slide shows you the percentage of patients in whom that therapy is prescribed. And you can see both in all ethnicities, but also in all regions on the right side, that between 96% and 99% of women are prescribed this endocrine therapy. That is very good by international standards. The gold standard is to have more than 90%. So in that area, we are doing well. This slide shows those treated with chemotherapy, and the people who've had chemotherapy are those in the light blue. Chemotherapy will also get rid of that microscopic disease in a proportion of patients, but chemotherapy has significant toxicity, so you need a bigger advantage to agree to treatment in order to accept it. And this slide shows you that overall, in the top line, about 37% of women will be recommended and receive chemotherapy. It's roughly the same in the various ethnicities, perhaps a little higher in Pacific and Asian. It's very similar in all the regions, but it's very different in the age groups. In the younger women who have more aggressive therapies, as we've heard from Rena, 3/4 of the women will accept chemotherapy. In the screen age group, which is better outlook cancers already, it's only 37%. And in the older patients who don't tolerate chemotherapy quite so well, it's only a very small proportion. It's similar figures for the stage, which is the 3 bars underneath that. And the bottom one of those 3, again, 3/4 of the patients with grade 3, the aggressive tumors, will agree to chemotherapy. In the middle graph, about half of patients with stage 2. And in stage 1, who already have a good prognosis, only about 15% of those would be recommended to and receive chemotherapy. And it's the same on the bottom 3, the 3 lines just below that. for grade. Grade 1 doesn't need chemotherapy, except in a few isolated incidents. Grade 2, about 30%, and grade 3, about 75%. This shows you the rate of chemotherapy in the different regions. The red line in the middle is the overall patients. The other lines are the different regions, and you'll see that they're all roughly the same. There is an exception in the dark blue line, and that from about 2012, that blue line, the rate of chemotherapy seems to drop. That's in Waikato. We don't quite know why that happens, and that needs further investigation. But you can see at the end in the group, at the very last line, vertical line, in between 2018 and 2019, there's quite a big difference in the rate of chemotherapy between the top region, which is Auckland, and the region with the lowest rate of chemotherapy in Waikato. Some people will decline chemotherapy. It's difficult to know quite what it means by decline, because sometimes they decline it because the doctor they're seeing says, well, I don't think it's going to do you much good. But if it's recommended, but you could have it if you wanted to do the very best you can. You can see that overall, on the pale blue line at the bottom, about between 13 or 14 and 17% decline, with the exception of Asians who decline in a lesser degree than other patients. Her2 therapy is a newer therapy. It's only been around for probably about 15 years. The Her2 gene was noted to be overexpressed in a number of breast cancers about 30 years ago. And these breast cancers had a more aggressive outcome. This led to the development of the drug trastuzumab, or Herceptin as it's more commonly known. And this shows you the rates in light blue of who receives Herceptin. You may remember that a number of years ago there was considerable controversy about when and whether this should be made available to breast cancer patients. But you can see overall, on the top line, 82% of women will have anti-Her2 therapy. This has to be given for its best effect with chemotherapy. The ethnicity is in the 4 lines below that, and around about 80% of patients will have Herceptin, perhaps a little higher in Pacific and Asian women because they have slightly higher rates of Her2 positivity. Again, the regions are relatively similar, although the use of Herceptin in Waikato is somewhat less. As you can see there, only just under 70%, and in Christchurch is also a little less than in Auckland and Wellington. Age makes a big difference. The younger patients, nearly all will receive Herceptin. Even the middle group, if they're Her2 positive with that nasty potential prognosis, over 85% of those will have Herceptin. And even in the very old, not very old, they're over 70s, nearly half of them will have Herceptin. And again, in the grades, Herceptin is used widely in all grades, but more in higher grades. Now we look at survival. This is survival of breast cancer by age, and age is a big predictor of survival. As we've already said, the pale blue line at the top is the screen group, the group with the better cancers, and they have a better survival with an 82% 10-year survival. An 89% 10-year survival. The red line below that is younger women doing somewhat worse with 82% 10-year survival, and the over 70s at 80%. But if you look at the table on the bottom right, you can see that for each of the age groups, there is improvement over time. So that, for example, in the 44-year-old age group, in the early days of the register, the 5-year survival was 81% and 10 years 75%. And in the latest group at 2015, 2017, the 5-year survival was 10% better. We don't have 10-year survival in that group because we haven't followed them for long enough. It's the same in the mid group and in the older group. This is survival by ethnicity, and it's been known for a long time that the Maori and Pacific do somewhat worse. They're the two bottom lines with worse survival. But when you look at this closer, it's very interesting, because here are the graphs for each 3-year composition of treatment. And in 2003, you can see that the survival is somewhat worse, but over subsequent 3-year groups, all the curves are moving up. But even more important than that, the curves are getting closer together. That means that everybody is doing better, but the people who started with a worse prognosis are doing even better. They're catching up with the people with the better prognosis. And this is shown in some of these tables here. Here is the Maori, the top is the Maori over time. The 5-year survival is improved by 11% over the 12 years of the register. Pacific by 10%, Asian by 10%, and European so a little bit less at 7%. Here is the final slide showing the overall survival over the duration of the register for 16 years. And you can see that the curves have got slowly higher. Every 3-year cohort of patients is doing a little bit better than the previous 3 years. And if you look on the right-hand side at the bottom, you'll see that the New Zealand figures of 5-year and 10-year survival is very similar to Australia. There's often been comments that we don't do as well as Australia. On these data, we do just as well. And it's somewhat better than in the UK. The UK figures are age adjusted, whereas ours and Australia's are crude. But we have done age adjustment on these figures, and they have very little change. So we're doing as well as those people we like to compare ourselves with. There's a lot of data here, a lot of opportunity for further studies, but I think we know we're doing well, and we're doing particularly well in the groups that at the beginning of our analysis were doing worse than anybody else. So now, in fact, the Maori survival in the latest group is fractionally better than the survival of similar European patients. I think we're doing well, but we need to do better. Thank you.
Great, thank you so much, Ben, and that was very enlightening. Now we're running reasonably tight on time, so we're going to pop back to Rena to talk a little more about what might happen next. But Rena, if we can just keep that to a couple of minutes so that we can, because we do have quite a few questions waiting, so we'll look forward to getting to those in a moment.
Okay, thank you, Adele. And yes, I'll keep it very short. As you've heard over this evening's presentation, there is a lot of work that went into producing this audit and this report, and we've done well because we've shown that we've done over the years, we've improved in treatments, in follow-up, in detecting breast cancer, and we are doing well. But also we have found that and identified certain areas where we need to do even better. And at Breast Cancer Foundation, we've sort of prioritized several groups that will need further study, will need more support, and will need more work done around them to improve survival rates. The first group has, as you've heard for the whole evening, are the high-risk women, Maori, Pacific Island, patients with large tumors, high-grade and late-stage tumors. And I will just highlight one or two of the underlying factors. The first one is that we did talk about 10-year survivals, and we are concentrating on 10-year survivals just because with a lot of our patients that are hormone sensitive, they will present with either recurrence or metastatic disease later in their pathway. So that will be one of our focuses and challenges. The second that I would really like to highlight is that because of COVID, because of lockdowns,